All right. Well, I'd love to welcome Dr. Jonathan Marin to the CBSSM Grand Rounds for Bioethics. We are very fortunate to host Dr. Marin, who is a pediatric oncologist, bioethicist, health services researcher, and educator. Clinically, he cares for children with cancer at Boston Children's Hospital and the Dana-Farber Cancer Institute. He also serves as a clinical ethicist at those institutions and is a member of the core teaching faculty at the Harvard Medical School Center for Bioethics. His research focuses on the intersection of ethics and decision-making, perfect for our center, with a particular interest in pediatric cancer genomic sequencing and other advanced and emerging technologies. He currently serves as chair of the Ethics Committee of ASCO and his work has been published in numerous prestigious journals, including JAMA Pediatrics, the American Journal of Bioethics, JAMA Oncology, JCO, and Pediatrics. We are extremely fortunate to be able to host him to speak on a subject that I know will resonate with so many in our community. If you've got questions, Dr. Marin has very kindly said that he would be happy to receive questions during the talk through the Q&A feature. I will be happy to interrupt him if it seems appropriate. It will have some time for a Q&A at the end. So please send questions through Q&A. And if you think it's urgent that I interrupt him, let me know because I'll monitor the Q&A because it's, I know, impossible, Dr. Marin, to be monitoring a Q&A while delivering one of these Zoom talks. So thank you for being here with us and welcome.
Well, thank you to Dr. Jagsy and to everyone at the center and for all of you for joining. I'm excited to, even virtually, to be able to join everybody for this. So let me quick share my screen. We can get started. How's that looking? Perfect. All right. So today, as Dr. Jagsy mentioned, so I will be talking to you about some ethics and decision making in adolescent medicine. So is age really nothing but a number? So quickly, a few disclosures. I am a member of the Ethics Advisory Board for a company called Partner Therapeutics and received an honorarium for a lecture I gave to Sanofi Genzyme, interestingly, about ethical issues, but certainly neither of these relate to the topic being discussed today. Importantly, a couple of other types of disclosures. I am a pediatrician, I'm an oncologist, a bioethicist, and a researcher. I am not, however, an adolescent medicine physician. As a pediatric resident, I actually was absolutely scared of adolescent patients and felt completely ill-prepared to go into a pediatrics practice taking care of adolescents. But then in the years since then, I've it's come to be that this is a patient population that I absolutely love working with, in both clinically and in terms of research. Adolescent decision-making really is one of the most complex decision-making processes and areas in pediatrics. So it's a particularly interesting and important one. And pediatric decision-making as a whole is really one of my particular areas of interest. You'll notice throughout the next 40 minutes or so that each of my different hats as pediatrician, oncologist, ethicist will come up in various different ways. And so you'll probably notice that. So to orient everyone, we'll first start with a bit of a case and then talk a little bit about some of the background information regarding adolescence that informs decision-making and the ethics therein. Then talk explicitly about sort of the current state of the art in adolescent decision-making, come back to our case and a couple of tweaks to it, and then talk a little bit about some future directions and conclusions. As Dr. Jagsy had mentioned, please do feel free to interrupt, put questions or comments in the chat, etc. So let's first jump in with our case. So to start us off, let's imagine this patient. This is a semi-fictional case, and I'll explain in just a little bit exactly what I mean by that. So R is a 16-year-old female who is diagnosed with low-stage Hodgkin lymphoma with chemo plus or minus radiation, depending on her response to chemotherapy. We'll say that her cure rate is about 80%. Today, this approaches 95% or more. But at the time, and I'll come back to exactly what I mean about by at the time, it was thought to be around 80%. So she started chemotherapy, developed some of the typical treatment toxicities that we see, including decreased blood counts requiring some transfusions, fatigue, alopecia or hair loss, and some nausea and vomiting. Again, for her, these were particularly distressing, but these were well within the range of what we commonly see with the chemotherapeutic drugs that she received for this disease. So after 2 cycles out of a planned total of 6, she decided that she had, in her words, had enough and wanted to stop treatment, stating that she believed that the treatment was killing her. To be clear, it was certainly not actually killing her, but this was her way of describing her perception of things. And so, again, reminder that she's 16. Her parents were very actively involved with all of this, and her parents absolutely wanted her to complete the therapy that was recommended by her clinical team. But they ultimately supported her decision to stop because she threatened to run away if she was forced to undergo further chemotherapy, which she didn't want. And so her parents email you. They tell you that, well, we're not going to be coming back for any additional chemo, but they don't want to just not be seen anymore. They do want to continue to be followed under your care for surveillance imaging, post-treatment follow-up care, everything else except for the chemotherapy that you feel is necessary for her treatment. This is distressing to many members of the clinical team, and some of them wish to contact the state's Department of Family and Services, or DCF, though not when you ask them, not clear if they feel that this is medical neglect, child neglect, or if there's something else that could be done, but really just a lot of discomfort about how to handle this situation. So imagine now that you're are ethically inclined oncologists, and so what do you do? So in a moment, I will open up a poll, and so you can either respond with your choice, either via text here at by texting this, what we see here, or at this website, pollev.com/John Marin. And this will be up on the next slide as well. All right, so you should now be able to respond. So we have a couple of different options. So one, you can support the patient's informed refusal of further chemotherapy, because we can assume for a moment at least that this is an informed refusal. She understands what's going to happen, that their cancer will likely come back and that she may ultimately die, but continue to provide follow-up care. You can support her refusal of further chemotherapy, but refuse to provide further follow-up care. You can contact Protective Services or DCF with the goal of legally mandating further chemotherapy. You can contact your Protective Services with the goal of effecting legislative change about medical neglect. So I've intentionally here not shown an option of I don't know, or contact the legal team, or contact your ethics consultants, because presumably we all would choose one of those, but would like to see kind of where people are if those are not options. All right, so we got a little bit of a mix. I'll give another couple of seconds for people to provide responses. All right. So with that by way of introduction, let's talk a little bit about, excuse me, about adolescence and some of the uniquenesses there. So just about every lecture that's ever been given to medical students and other trainees about pediatrics includes a quotation, something along the lines of children are not just little adults, which is absolutely true. I'd amend this a little bit and say that, well, adolescents indeed are not little adults, but adolescents also aren't just big kids. So whereas this applies, adolescents are particularly in a unique place. And so where does that place land? In a lot of ways, they're really stuck in this very unique but challenging middle points, this sort of a fulcrum, so to speak, between childhood and adulthood. So what do we think about adults? So about children. So children, one, do not have the ability to make autonomous decisions. They're developmentally immature, and we'll talk in a couple of moments about what exactly that I mean by that. They're physically dependent, usually upon their parents, but certainly on others of some sort. And they have pretty limited legal authority. On the other end of the spectrum, adults are presumed, all things being equal, to have autonomy and to be able to make autonomous decisions about their medical care. They're developmentally mature. They're physically independent in most cases, and have full legal authority to make decisions about their medical care. And as you might expect, adolescents fall in the middle, in between these in a lot of ways. They have what we sometimes will describe as burgeoning autonomy. They're not able to make autonomous decisions, but certainly have more of a say and more of a life experience to inform that say than do younger children. They're sort of developmentally in between, physically gaining independence, and have a little bit of variability in their legal authority. And we'll delve into each of these in just a little bit in just a couple of moments. So in just about every way, adolescence is a time of huge changes. And those here who are parents may be experiencing this with their own children. We all have gone through this ourselves. So certainly on the one hand, there is the change of physical developments, both in terms of sexual development, linear growth, physical maturation, but just as importantly, if not perhaps more so, neurodevelopments. And so while the brain reaches adult size actually relatively earlier, late in childhood, a lot of the actual development of the brain doesn't take place until much later. So both the myelination and the prefrontal cortex, that really doesn't happen until 20s, 30s, and sometimes even a little bit later. As a result, there's this discordance. Our socio-emotional, or sort of our hot centers, develop at the time of puberty, and our cognitive control, some of the cold centers, or sort of the cooling controlling mechanisms, oftentimes develop around age 30. And in some ways, this, at least in part, accounts for some of the less than perfect decisions that many of us made as teenagers, and that we often see and attribute to as commonly taking place in adolescence. And so what about the legal status? So, well, the age of majority in most states in the United States, though not all states actually, is 18. Importantly, though, clearly nothing magic happens when somebody turns 18. They weren't a child the night before. You wake up on the day of their 18th birthday and suddenly you're an adult. We all know that that's not really what's happening. In practice, minors as they get older play a larger role in their decisions with increasing age and with increasing significance of the decision. And this is highlighted in what is known sometimes as the rule of sevens, which has over time become a guideline or perhaps rule of thumb that states that for children under 7 years of age, assent is not needed for medical decisions because they simply cannot be competent. For kids 7 to 14 years, assent isn't required, but the child should be informed of medical plans because they're presumed not to have competence, but clearly should have some sort of role. And for minors 14 years and older, assent is required because competence for them is assumed in absence of evidence otherwise. And this rule of thumb, this rule of sevens, informs many institutional practices for when to require or consider assent for children and adolescents. But let's think about some of these exceptions to this legal status, this cut point of 18. So first of all, many people may have heard of the mature minor doctrine. And this idea, just generally speaking, a judge determines if a legally incompetent minor, because minors are legally incompetent, whether they can consent for their own medical care. In this case, for states that do have a mature minor doctrine, because not all do, this usually considers age, maturity, cognition, social situation, and other factors like that. Another side of that coin is the Emancipated minor statutes. And what this is slightly different than mature minor doctrine. This is a situation in which adolescents who are living separately from their parents can provide consent for their own medical care under certain circumstances. So one, if they're financially independent, if they're married, and or if they're in the armed services, so the Army, Navy, something like that. Again, this is different in different jurisdictions. And then finally, there are certain special circumstances. In many, if not most states, adolescents can provide consent without their parents' permission for certain protected categories of healthcare, some of these sort of special categories of healthcare. This includes sexual health, including contraception, sexual transmitted infection testing, things of that nature. Mental health in terms of counseling, receiving medications for mental health services, etc. Substance use, things of that nature. Importantly, though, there is a huge amount of variability from one state to the next across the country. And this is really a moving target because states, every couple of years, these rules change. To kind of bring this home, for instance, in Michigan, I believe that the current law states that adolescents can provide consent without parental permission for most, if not all, types of contraceptive services. But there's sort of this interesting caveat that the clinician has the option, but not the obligation, to inform the parent about this. So your neighbors to the south in Indiana, that option actually does not exist. It's not built into the law. And so adolescents can consent without parental notification, which this is a small, but actually a particularly important distinction when we're talking about two neighboring states. And so let's think about some of the changes that have been taking place recently. So many states over the past couple of years have actually passed or amended laws to allow adolescents to provide independent consent for additional healthcare services outside of those that I just mentioned. Sort of an expansion of these special exceptions with a particular focus on vaccination over parental objections. This gentleman here is Ethan Lindberger. He was in the news a couple of years ago when just before his 18th birthday, he wanted to get vaccinated, but his mother, who was basically his mother said no. And so once he turned 18, he went and got all of his childhood vaccines. But since that point has really become an advocate for adolescents being able to get vaccinated despite parental refusal or parents not wanting to. This is actually a picture of him speaking in front of Congress about that very point. And so actually at the present time, there are a couple of states who are considering additional statutory changes allowing for adolescent vaccination over parental objections and various other considerations like this. All right, so what about the ethics here? So we've talked about the legal pieces, we've talked about the developmental pieces. Obviously, it's really hard to make sweeping statements about the ethical status of a large group like adolescents, but we could perhaps use as a proxy how adolescents are discussed in, for instance, the American Academy of Pediatrics guidelines on consent and decision-making. And so the first official guideline that the AAP put out in 1976 on this topic, adolescents really receive almost no mention. Just about 20 years later, 1995, that statement was completely revised, really brought down to the struts and completely rewritten. And in the revised version, there was a pretty significant discussion of adolescents, stating that they should be involved in age and developmentally appropriate fashion, and should have a significant role when possible in decision-making about their medical care. And then again, 20 years later in 2016, this statement again was really rebuilt from the ground up. And even more so than in the second version, this one has a really significant focus on adolescent decision-making. This is a much more comprehensive document and a really fantastic one. That's this one here. by Aviva Katz. And it has a really detailed discussion of adolescence, including a focus on adolescent treatment refusal, like in our case. And as I mentioned, just as in our case, in the setting of treatment refusal, though this is a particularly rare thing, particularly refusal of potentially life-saving treatment, it's particularly challenging and perhaps not surprisingly, particularly controversial. But it does get at some of these core and really unique features that are related to adolescent ethics and decision-making. So perhaps not surprisingly, a variety of bioethicists and other commentators really continue to debate about when adolescents should be able to be permitted to refuse potentially life-saving therapies, or even whether that should be deemed legally or ethically acceptable whatsoever. So some of the arguments that many have raised against permitting adolescents, like our patient R, to refuse potentially life-saving therapy, so include, for one, that this is a pretty final and irreversible decision. If indeed you permit the adolescents to refuse life-saving therapy, and then they ultimately die, clearly there's no turning back from that. As we alluded to before, the neurodevelopmental immaturity, there's certainly room for further development in the adolescent brain, and as a result, their decision-making processes. Particularly in the setting of oncology, but in many other medical decisions, there's oftentimes quite a bit of uncertainty around our ability to prognosticate about what will happen with or without a given treatment. And actually, there's been a number of studies that, though we like to think that we as clinicians no longer act in a paternalistic fashion, there really is a tendency that whenever there's a setting of disagreement, particularly between adolescents and parents, clinicians tend to support whoever agrees with the clinician. And so that is one of the thoughts of, okay, well, if we shouldn't be pretending that we're going to support an adolescent, where we're only going to support them if they agree with the decisions that we are recommending. So overall, this is just really confusing. There's a lot of moving parts, and everything that we're talking about here in adolescent decision-making is really, really challenging. Guidelines continue to change. The laws themselves continue to change. There's actually different laws or different interpretations of laws in different jurisdictions, just as I mentioned with the example between Michigan and Indiana. And actually, the differences are much more stark in other parts of the countries. And this results, in some cases, in some pretty illogical paradoxes. For instance, in some states, the laws are set up such that an adolescent mother might be able to actually provide permission for her young child to receive vaccines, but that adolescent mother would not be allowed to provide consent to her own self receiving vaccines. This gets even further complicated when we're talking about new emerging technologies or new areas of medicine. So some of the things that a lot of my research is in, so thinking about genetic testing or treatments informed by genetics, when we're talking about results that may or may not actually impact an adolescent until they are an adult, and whether we think about this differently in the setting of research, consenting to research or participating in research differently than we might in clinical care. So clearly a lot of complexities here in the area of adolescent decision-making. So with that in mind, let's now think about kind of where we stand. So the sort of the current state of the art. And I'm going to use here oncology as a model clinical area for exploring this sort of current state of the art in adolescent decision-making. One, in part because, as I mentioned, it's my own specialty. This is an area that I'm familiar with, but for a couple of other reasons as well. So one, there are actually several cancers with a particularly high prevalence, specifically in adolescents or adolescents and young adulthood. So including lymphoma, the cancer that our patient in our initial case had, various thyroid tumors, certain brain tumors, actually a whole number of cases of particular cancers that are of particularly high prevalence in adolescents. And also in the oncology setting, there's sort of several unique considerations that add complexity and importance, clinically, ethically, and otherwise. So one, these decisions are particularly time sensitive. These, in some cases at least, are rather life and death. The treatments that are being considered, whether chemotherapy, surgery, radiation, or a combination of those, often require a long length of treatment, and also potentially both short and long-term toxicity, and pretty significant toxicity. As I alluded to before, there's also quite a bit of outcome uncertainty. Even if we can say, as in our patient's case, you have an 80% or even a 90% chance of survival, the error bars around that in most cases are pretty significant. And finally, because of each of these things, the length of treatment, the toxicities of treatment, the uncertainties, the degree and the frequency with which a patient will be in clinic or in the inpatient setting, having an adolescent fully engaged in their treatment planning, in their treatment plan, is particularly important. So what do we know about adolescents' roles and decision-making? Well, in part, simply that we have a lot more work to do, that there's a great need for improvement here. So over the past couple of years, a couple of studies have come out that discussing adolescents' decision-making and adolescent roles in their decision-making in oncology. One study demonstrated that, in short, most adolescents really do want to share decision-making responsibility with their oncologist and with their parents. But unfortunately, about a quarter ultimately express significant regrets for the role that they played in their initial cancer-related decisions. So both about their treatment, about and about their supportive care and measures like that. Similarly, when thinking about toxicities, nearly all adolescents, so 87% of adolescents and young adults, state after the fact that they want to receive information about long-term treatment toxicities, but only about half report actually receiving high-quality information about these. So clearly there's a disconnect between what adolescents want, both in terms of their role and what they want to learn about, and what we actually provide them, information and otherwise. And unfortunately, some of these shortcomings are even more evident or perhaps more extreme when we move further down the line and consider either the relapse refractory setting or even further down the line down to end of life. And so one recent qualitative study demonstrated that adolescent engagement is actually really limited in conversations with oncologists and their parents about treatment decisions in the relapse refractory cancer setting. So this study demonstrated that most of the engagement, most of the time when the oncologist was speaking directly to the adolescent and querying them on, tell me, I want you to talk, tell me what you have to say, was really related to social or personal information, tell me about your medical history, and not actually about treatment preferences, what matters to you, things of that nature. And in this study, and I think that this anecdotally probably fits with what many of us have experienced, only about 7% of the time of spoken word actually came from the adolescent, with the remainder being from the parents or the oncologist. And importantly, that distinction between what's being said or thought by the parent versus what's being said or thought by the adolescent, unfortunately, those two things are oftentimes probably not concordant. A study that just came out a few months ago demonstrated that only about 40% of families are aware of adolescent preferences about discussing end-of-life care. So when to talk about, when to begin these conversations, what the adolescent wants, what matters to them, etc. There's actually a very significant discordance between parent and adolescent responses and perspectives about their end-of-life preferences, life-sustaining therapies, and death. So what the parent thinks that the adolescent wants is actually quite different in the vast majority of cases with what the adolescent actually wants. All right, so with that said, let's come back to our case. So as a reminder, we have our 16-year-old with highly curable Hodgkin lymphoma. She wants to refuse further chemotherapy, and the parents are reluctant but support for refusal of chemotherapy. As some of you might have already guessed or identified, this isn't simply just a fictional case that I made up. It's actually sort of an amalgam of several cases that became relatively well known as they played out in the public space. I sometimes tell my bioethics students that if Hodgkin lymphoma didn't already exist, the bioethicists would have made up something just like it, because it really lends itself really well to talking about some of these ethical challenges. It's a disease that happens primarily, or at least largely in the adolescent period. It's quite curable, but comes with some pretty significant short and long-term toxicities. And so these conflicts around treatment, though rare, are particularly difficult. And these conflicts do actually arise with a little bit more regularity than in some other settings. All right, so where did I come up with these details? So the first case that some people might be familiar with is that of Billy Best. So Billy Best was diagnosed in 1994 with Hodgkin lymphoma at age 16. He was here in my current state of Massachusetts. Billy decided to run away after a couple of cycles of chemotherapy. His parents agreed not to force further chemo if he returned, and they together instead opted for alternative therapies, including some herbal teas and injecting a proprietary natural substance into his lymph nodes. The Massachusetts Department of Children and Families was called, but this case never went to court. Contrast that with another case a couple of years later, that of Abraham Cheryx. So Abraham was diagnosed again with Hodgkin lymphoma in 2005. He was also 16. This took place in Virginia. Rather similarly to the case of Billy Best, after a couple of cycles of chemotherapy, Abraham and his parents refused further chemo, opting instead again for alternative treatments, including herbal supplements and some pinpoint radiation provided by a non-oncologist. This case ultimately was reported to the state, and Abraham's parents were charged with medical neglect. This went back and forth throughout the Virginia courts for a while, and the state of Virginia ultimately passed what is now referred to as Abraham's Law, which allows parents to refuse medical treatment under a set of clearly defined circumstances, but such that would not be classified as medical neglect. And a third and final case is that of Cassandra Callender. So Cassie was diagnosed in 2014 with Hodgkin lymphoma. She was 17 at that time. And this was in the state of Connecticut. Similarly to our other two cases, she ran away after a couple of doses of chemotherapy. She was supported by her mother in running away. DCF once again was called, and in this case, after going through the courts, Cassandra was placed in DCF custody. She was deemed by the courts not to be a mature minor, hearkening back to some of the conversations from earlier. And ultimately, Cassie was given chemotherapy over the explicit objections, both of Cassie and of her mother. It's not entirely clear practically how that took place, but there are some reports that she actually would receive both physical and chemical restraints for this to take place. All right, so what's happened with each of these now? So Billy Best actually continued after stopping his chemotherapy and starting alternative medicines. He continued these alternative therapies for what's thought to be about 6 or 9 months. And interestingly, his cancer never returned. He wrote a book about his experiences. That's what this picture is here, and actually spoke quite often about his views on patient advocacy and advocating for patient rights. Interestingly, it's thought now that perhaps he didn't need as much treatment as was thought, and over the years since then, we have cut down the number of cycles and amount of radiation and things of that nature for low-stage Hodgkin. So it's thought that perhaps what he received at the time that he ran away might be all that he would receive were he to be diagnosed today. Abraham Cheryx, so his cancer relapsed a couple of times over the years after he stopped recommended therapy. He initially treated these relapses with herbs, but then returned to his conventional therapy team in Virginia and received relapsed chemotherapy and then an auto transplant. As best as I'm aware, he is alive and healthy today. Interestingly, he has been interviewed a number of times in the years since then and states quite eloquently that he doesn't regret the decision that he made and is proud of him voicing his perspective, but says that now he certainly would make a different decision now, but appreciates the way he thought about it at the time. And then finally, Cassandra Callender, she was held in the hospital to complete her chemotherapy and then ultimately was released following chemotherapy completion at the time of her 18th birthday. And she relapsed a couple of times, initially treated with some alternative therapies, including herbs. She actually traveled down to Mexico to receive some alternative therapies, and then ultimately with conventional chemotherapy and an auto transplant. And then, unfortunately, the news came out this past spring that Cassandra had died just in this past May. So, all told, there are quite a number of similarities between these cases in the sense that they have quite a similar disease, age, and prognosis. All were interested in and ultimately in some way, shape, or form opted for alternative therapies. But at the same time, there are slightly different role or perspectives of their parents, and the parents were involved in different ways in each of these cases, and a really vastly different role of how the healthcare institution responded to the patient's and parents' refusal of treatment, the way that this played out in the courts and the process by which that all took place. And really vastly different outcomes, both clinically, psychologically, socially, and otherwise. All right, so then knowing now what you know, what would you say that you would do in our patient's case again? So again, we have here our a couple of different options. As you may notice now that the options that I provided you here were not just ones I made up, but rather the sort of the different iterations of or different versions of what actually took place in each of these different cases. All right. So perhaps during in a moment in question and answer, we can talk a little bit more about the thoughts behind some of these different options, because these certainly are fascinating. All right, so let me get back to my slides here. All right, so in a couple of last minutes, let's think a little bit about where we go from here. So clearly we have improvements we can make in how we think about adolescent decision-making, the ethics therein, and importantly, how we integrate adolescents into their decision-making about their healthcare. So a few ideas that I think that perhaps could provide us first steps in a way forward. So one, I think we need better clarity with regard to what we mean by shared decision-making with and for adolescents. Shared decision-making is something that we consider to be sort of the standard of care and the standard way that we practice in medicine. It's less straightforward in pediatrics. Even identifying what shared decision-making means in the pediatric setting is less clear, but it's even more complicated when we're talking about adolescence. So I think we need to have a better understanding of, one, what it is, and whether it's really what adolescents want. Do adolescents want to be have a main role in their decision-making? And if so, how do we optimize that? How do we ensure that adolescent voices are heard when we want that to be the case? And how do we ensure that the role that the adolescent wants in their decision-making is aligned with the role that we're providing, since clearly the data demonstrate that at least in some cases that's not taking place right now. And along those same lines, how do we improve engagement of and with adolescents throughout the illness trajectory? So again, coming back to what are adolescents' preferred role in their treatment decision-making? What do or do not they want? And then really, how can we do better in all of this? Because clearly, at least in some situations, we're not doing a great job. And again, no guarantee by any stretch of the imagination that improvements in these areas will avoid refusals of treatments like in the cases that we've been talking about. But certainly, I think they bring up the questions that in those fringe cases like that, because they truly are fringe cases, it really harkens back to these important fundamental questions. So a couple of other thoughts on how we can, ways to move forward. So one, improving our understanding of and how we define competence in adolescence. So in adults, there are very well-defined tools to help determine whether an adult patient has capacity or competence for making medical decisions. There's a variety of validated measures for this. There's a variety of tools that people use at the bedside. There are a few of these in pediatrics, but they're certainly not as rigorous or as consistently utilized. So it's possible that we could develop some of these like we have for adults. Not clear whether this would be meaningful or useful, and also not clear, but important to think about how this might be utilized, given that competence in the adolescent setting has such challenges from a legal, ethical, and practical perspective. And then finally, thinking about consistency. And so as I mentioned a little bit before, there is a huge amount of variability about how we treat adolescents in terms of their role in decision-making and their authority in decision-making, both across jurisdictions, and then as was shown with a couple of example cases today, even across individual cases, particularly so when we're talking about conflicts and when there's disagreements either between the clinician and the adolescent, or between the parents and the adolescent, or a combination of those. So I think perhaps this might be the place we need to be most thoughtful going forward about what is the optimal process by which we can do this, particularly given the fact that in all likelihood, just because this is the way the United States works, we're not going to have consistency across states, across all jurisdictions in the way that the law is set up, but figuring out how we can optimally proceed in light of that, and how we can ensure equitable application. It certainly does not seem ideal if two patients in similar scenarios undergo completely different processes, both with their clinician, with the courts, and everything in between. All right, so to summarize, and I look forward to hearing what others have, others' thoughts and chatting about this a little bit more in the last couple of minutes we have. But unquestionably, adolescents are a very unique population with particularly unique needs. These range from developmental, legal, ethical, practical, and otherwise. One piece of this that I didn't mention in great detail, but we could perhaps talk about in the question and answer session, is this practical piece. Because even for those, for instance, who would recommend proceeding with treatment over the explicit objections of an adolescent, the question of how one practically would do that, even if you feel that it's legally and ethically supportable, is really hard. In Cassandra Callender's case, excuse me, some of the public reporting that we have makes it sound as though they actually quite literally had to hold her down or sedate her for intermittently for several months to infuse her with her chemotherapy. That's a big ask. And that's a very different thing than saying we're going to just give a medicine through the IV one time over your objections. So even if it's legally, ethically supportable, perhaps the practicality of it adds different challenges. And with all that being in mind, we're still really finding our way in understanding how best to integrate adolescents' voices, their values, and their perspectives into treatment planning, into treatment decisions throughout the illness trajectory. And so this is particularly evident when we get into these really complex, nitty-gritty, challenging situations, whether we're talking about adolescent refusals, whether we're talking about end-of-life decision-making. A lot of these areas are particularly complex. And of course, there remains still a significant amount of work to be done, but a lot of thoughtful and smart people really thinking hard about this. So that is all I got. Thank you so much.
Thank you. Well, that was just a wonderful tour de force, and we are really appreciative that you've given us so much to think about here. I'm already seeing chats pop up with questions. So I have a question for Amy about whether we can unmute the panelists or the audience members to ask their questions if I give you their names. So I'm going to try that. If not, I'm going to read the questions out loud and attribute them. So the first question here is from David Sandberg. Can the quality of decisions, can we unmute? I'm sorry, first I won't read it out loud. David, if you're able to unmute yourself.
Yes, yeah. I have. So I think that the decisions that you described, as thorny as they are predicated on the assumption that we've done a pretty good job of shared decision making. I question that all the time. I don't think there's good evidence. In fact, there's lots of evidence to show we don't do a good job of it in adult medicine. And there is some evidence in pediatrics that shows that it's no better. So if the individuals are not involved in getting the information they need to make informed decisions, to focus on what they decide and to take action based on that seems putting the cart before the horse.
I couldn't agree with you more. I mean, I think that's absolutely a fundamental foundation here is ensuring whatever we mean when we say shared decision making, that we are integrating the voices of each of the stakeholders, and it is not just the clinical team saying this is what we're going to do, sign on the dotted line. But I agree that I'm talking here a lot about some of the areas on the periphery but to be able to get there, we have to have a better understanding, one, of what we mean by shared decision making, and two, how to do a better job of that, or at the very least by integrating more both parents and, in this case of adolescents, the patients themselves, their values, their perspectives, their goals, and then considering how to integrate all of these different pieces of this really complicated puzzle. Couldn't agree more.
And I just might add to that, how does one document the process differently from how we see it's documented in the medical record, where it says certain things were discussed, they agreed, et cetera, but to actually have documents that the patient, the caregivers, the providers are all involved, that help to document.
Yep, that's a really important piece of this as well. Absolutely.
Thank you. I know that Dr. Andy Schumann had a couple of questions, if he's able to unmute himself.
Sure, thanks so much for a wonderful talk. One of my questions relates to how clinical consent versus research consent are contextualized differently in this respect with regard to involving adolescents in cancer trials versus cancer treatment.
Yeah, I mean, so in practice, a lot of institutions have made it such that whereas assent is recommended, though not obligated, for clinical care, but it is absolutely obligatory in the research setting. And that's some of that is based on regulatory requirements at the national level. But I think most institutions also have that really kind of dictated pretty distinctly as well. I mean, because again, I mean, the lines between research and clinical care are becoming more and more blurred, particularly in the era of precision medicine and things. So that gets particularly challenging and particularly important to ensure that parents and adolescent patients understand what is research and what is clinical care and when we're making that distinction and what that actually means. But absolutely, I think we do need to be careful about making sure to be clearly distinct there, and that absolutely the adolescent voice probably deserves even greater consideration when we're talking about enrolling in research in comparison to clinical care.
Thank you. Dr. Shimon, I know you had another question. Would you like to ask that as well?
Sure. So COVID's always the elephant in the room, and the virtual setting has certainly complicated and contextualized the way that we interact with patients. In your practice, as well as from a broader standpoint, how do you see the conversion to virtual-based care influencing the informed consent interactions with adolescents?
So I would be really interested if others who are on the call have had other different experience with this. My own personal one in my practice has actually been that adolescents have in many ways benefited disproportionately from the virtual space, just because in many ways adolescent patients are the ones who are most savvy with all of the technical stuff, and it makes for some very funny clinical interactions where the parents are fumbling through Zoom and the adolescents are pushing them out of the way to, come on, mom, I know how to do this. And it's been, it's appeared in some ways to actually be an interestingly empowering thing, though certainly by accident. By no means was this intended to be like, oh, well, this is that we're going to look to find a way to empower adolescents. But perhaps this could be sort of a silver lining of us being able to say, hey, we learned that this is this was sort of an unintended consequence, but actually also an opportunity. But I would be also curious to hear if others have had a similar experience to this, or if mine has been sort of unusual. I know others at my institution have had similar things, but that could be a sampling bias.
Do we have any comments from the audience about that? If so, I think you can unmute yourselves. I think you can do it one at a time to comment. Otherwise, I'll move on. We've got a couple more comments and questions. Carly Pfeiffer.
Oh, hi. Yeah, no, I just was, it's a great talk, and I'm with Peds Cardiology, and I'm always just thinking that in these situations, would it be really helpful to have a peer-to-peer counseling system set up so they could hear from other people who have been through similar situations? And if you've seen that be helpful in any of these types of situations?
Yeah, I mean, I think in many subspecialty areas, there is a lot of these adolescent and young adult networks, whether those are organized in kind of an official capacity through the institution, or a little less officially through foundations or through social media or other means. And I think in many cases, those can be really helpful. It happens also, I think, quite commonly in an unofficial capacity, just that the adolescent patients tend to get to know each other over time just because they see each other in the waiting room or in the hospital. And the teens tend to want to hang out with the other teens rather than with the 6-year-olds, quite understandably. We do also have to just be careful about the potential unintended consequences of that, right? Because just the same way that we have to be careful in medicine about making decisions based on anecdotes rather than on kind of larger amounts of data, that's sort of what we're setting things up for if we're doing this sort of peer-to-peer thing. That a team could say, hey, this is what happened to me, which may or may not actually be what we commonly or regularly see. So there would ideally, having those connections could be really valuable, but having some way of figuring out or vetting who it is that is the peer that's providing the information, or having some kind of perhaps the ideal would be somebody from the clinical side, as well as sort of a couple of really thoughtful, helpful peers could be working together. That collaborative effort could be really, really valuable.
It's a really great idea. We have a point from Erin Bisco.
Hi. So I'm a study coordinator, and periodically I do work with kids. We have to learn how to talk to the kids as a study coordinator and as the parent. And I have worked with sickle cell kids as much younger than 7, but the kids really like being spoken to at their level with education. And have you considered talking with study coordinators about how they develop their language skills to work with kids and discussing clinical applications with them?
That's such an important point. Yeah. So I mean, when in the research that I do with my research team, that's actually one of the first things that I tell my research team is, unless there is an explicit reason that you need to talk to the parents, talk to the patient. Even if it in this is not just specific to adolescents. I mean, talking to younger kids as well. Making sure that they feel that they are involved and that they feel heard, and not just that they feel it, that they are involved and that they are heard, can be really important. And I think that goes for both the clinical setting as well as the research setting. But particularly when we're talking about adolescents, speaking directly to the adolescent patient, making sure that they know that these are decisions being made with them and for them and not about them. I think that's really important and an important first step towards improved engagement.
And I think we have time for one last question. And since there aren't any out there, I'm going to steal the opportunity to ask my burning question, which is, you spoke about the distribution of preferences regarding shared decision-making amongst adolescents and how they might differ from adults. Do we have empirical evidence about the distribution of preferences regarding shared decision-making among adolescents? Is this empirical work that's ongoing? What do we know?
So we have a little bit. It's really just the tip of the iceberg at this point, and not dissimilarly to what we see in similar studies in adults. There's a bit of variability that many adolescents, the majority of adolescents, do want to have a role in their decision-making process. Relatively few say that they want to be sort of the independent decision maker. And similarly, relatively few want to be left on the sideline completely. But between those two extremes, there's a whole variety of different options. And I would imagine that those data would probably vary quite significantly in different settings, in different clinical scenarios, in different, for instance, in cardiology versus in my world of oncology. And might vary over time, though I'm not aware of any data looking at this longitudinally. But I think
I might actually have something to add on that point. I'm conscious of time, and I want to get him in too.
Yep. Please.
So Rashmi, we did that in our cleft and cranial. I'm a craniofacial surgeon, and we have ongoing studies about that. And it's particularly interesting in our population because they're very preference-sensitive decisions about kids who are born with facial differences and how their face changes over time and how they feel about that. And so we're trying to do a lot of work in that exactly, in trying to develop a decision aid for different levels of, different ages of children, because they face different things at different times of their life functionally and how they interact. And so there's so much work to be done. It's just great to hear your work, Jonathan, and really appreciate you being here with us today. But some of us are trying to figure this stuff out. It's very difficult though, and it's very challenging. And I'm not even dealing with life and death decisions. These are very preference sensitive. It's interesting. We have a study where we found significant discordance in how parents thought their kids felt about their appearance versus how the kids actually felt about appearance, and versus how they tested on their quality of life scores. They're self-reported. So it's very challenging. I think David Sandberg sort of hit the nail on the head. Is we're not doing the best we could currently. I think there's a long way to with communicating these decisions, but I really appreciate your talk and your time with us today.